About 50% of our practice would involve the spine, and majority of this would be in relation to degenerative diseases, meaning the commonest being slip discs. That is a degenerative disease where the discs degenerated, they become soft and they pop out and cause pressure on the nerves and cause leg pain, back pain. So that will form the large majority of the spine cases that we will see. Sometimes because of the same process of degeneration, there is excessive movements of the spine more than normal, which may require stabilization. So that forms also a fairly large group of patients in this. Then occasionally we do see tumors and other diseases like some congenital conditions, vascular conditions. So this forms the bulk of our cases in spine. Like in Delhi, as I said, about 50% would form my practice in spine. But I go once a month to Guwahati, and there I think about 90% of the cases are of back pains and neck pains related to the spine. Here I tend to do slightly more of brain cases compared to the spine. But overall, generally, if you look at the practice of neurosurgeons all over the country, the average neurosurgeon would be doing about 50% spine and 50% brain, or maybe slightly more, maybe 60% spine and 40% brain. There are a lot of things happening in spine. We see a lot of advancements in instrumentation, in operative techniques. We ourselves in Fortis at Gurgaon, we have a top of the range, what we call a brain and spine suite, where we have a CT scan inside the operation theatre and a guidance system. So that helps us tremendously in placing instruments and implants very accurately and therefore very safely. There is a trend towards going more and more minimalistic in spine surgery with the smallest incisions and therefore the least amount of trauma, but without sacrificing the efficacy of these treatments. And I myself am quite avid follower of this philosophy, and I like to do most of my procedures minimalistically, and that helps patients a lot because it reduces the pain related to surgery so that they are back mobile and back to their normal activities as in the shortest time possible. Spine problem. The first thing that we do is, of course, take the history. We try to identify where exactly the problem could be. Spine, more than anywhere else in the nervous system, is extremely important to exactly pinpoint where the problem could be. So not only just say that it's a spine problem, but even go down to the particular nerve that is being affected by that problem. Because when we operate, we cannot explore. We have to know exactly what we want to do. And for that to happen, the first thing is an extremely precise history taking and a very thorough examination. Because on the basis of that, everything follows. Subsequently, of course, we do scans. We do an MRI in the majority of people. Then we go ahead and do CT scans. And the whole point of all these investigations is basically to ratify what we've examined and diagnosed just on seeing the patient without any investigation. So, because on that depends your results. There has to be a correlation. When things correlate, the results are good. When things don't correlate, the results are questionable. So once we have done these investigations and we are reasonably sure that we are on the right track, then we proceed ahead with the further treatment. Further treatment may be just pain management. So we have our pain specialists here who give injections, sometimes radiofrequency coagulation of the nerves, and various other procedures. And there will be some patients where we would just manage with medicines, and there will be the patients where surgery would be required. And as I said, with surgery we need to know precisely what we plan to do, and exactly the operative technique from what level to what level, and these things are then decided on the basis of whatever examination and imaging that we've done. The commonest operation that we do is for slip discs, and I personally like to do, again, in a minimal invasive way. So I like to use tubes, very fine tubes, and the whole idea of this is that we enter through the muscle. The muscle has fewer pain fibers, and so the whole operation is much less painful. And then we have a selection of tube diameters, and it's the bigger tube that we use is as big as my forefinger, and the little tube is the size of my little finger. So you can imagine these are the tracks that we use to remove the discs. Aside from that, we have procedures which are involved with fusion. Again, I like to do it minimalistically, and there I would use most commonly an incision which may be an inch in length, so it's slightly bigger than for removing a disc. And sometimes we can also do these what we call percutaneously, where we make small nicks just where the screws go in, and the whole idea of all this is to reduce the pain and the trauma of surgery as far as possible. And with these techniques, even with very old people, very frail people, we are able to achieve good results with a high degree of safety.